I want to say that was a great talk by Dr. Niski, and I was perhaps most impressed by his disclosure slide, because this is my disclosure slide. So I guess it shows my pecking order and all. So I'm going to talk about cardiac resynchronization therapy today, and what we're talking about really is demonstrated here on the right with this fluoroscopic view of a very early but still commonly used pacing system where we have a right atrial lead, a right ventricular apical lead. This happens to be a pacing lead, not a defibrillator lead, and then a left ventricular lead, so that we can achieve timing between the atrium and the ventricle, as well as between the right ventricle and the left ventricle. And many of you in this room, or most of you in this room, probably don't put these in, but the way that the leads go in is actually through the coronary sinus, which is shown here in the right atrium, the floor of the right atrium. And we have to fish this lead out into one of these veins into the left ventricle to achieve biventricular pacing. So the original description of this goes all the way back actually to 1984, and this is in the surgical literature, when patients undergoing aortic valve replacement who had left bundle branch block had epicardial left ventricular and right ventricular pacemakers placed to try to improve their post-surgical outcomes. But really, it didn't take hold until the mid-90s to late 90s when there was a description by Cazot et al. And by Jean-Claude Doppler and Doppler was really the first to put an endocardial coronary sinus left ventricular lead back in 1998. And then starting in 2001 really began the era of randomized control trials looking at the efficacy of CRT in heart failure patients. So here's my evidence slide. This is the summary of the major CRT trials, beginning with the early smaller trials, PATH-CHF and MUSTIC, as well as MIRACLE, which looked at outcomes which included basically clinical parameters and functional parameters, peak VO2, 6-minute walk time, as well as reduced hospitalizations. And then the later trials, including Companion, which was the largest study, which looked at all-cause mortality and hospitalization. And here's the inclusion criteria of these trials. They were all ejection fraction less than 35%. Really, all of them were patients who had some evidence of dilation of the left ventricle by left ventricular end-diastolic diameter. And then all of them, importantly, included patients with wide QRS durations greater than 120 milliseconds. Now, these trials actually did not stipulate they had to have left bundle branch block. They all just had to have a QRS greater than 120. And we'll talk about that a little bit. Here's the outcome slide from Companion showing improved event-free survival, mortality, and reduced hospitalizations in patients who received either a CRT, which is just the pacemaker, that's the biventricular pacemaker, or a CRT-D, which is the pacemaker plus defibrillator, versus optimal medical treatment. And you can see fairly significant absolute reductions with the pacemaker, biventricular pacemaker alone, an absolute reduction of 4%, an absolute reduction if you added the defibrillator component of 7%. And here's CARE-HF, another one of the trials showing a 34% reduction in all-cause mortality. When you look at the subgroups of Companion, it's interesting. I mentioned already the QRS width, and one important thing to consider was that, now this is again subgroup analysis, this was not a pre-specified analysis by any stretch in these trials, but this has been shown in multiple subsequent trials that the wider the QRS, the more benefit the patients get from CRT. So that when you get really more than 150 milliseconds on the QRS width, those are really the patients that seem to respond the best. And certainly left bundle branch block seems to respond much better than right bundle or IVCD. And in Companion, it was about 70% of patients enrolled who had left bundle branch block. And they really drove all of the response. So based on these randomized controlled trials, these are the updated guidelines from 2008 for CRT implantation. Left ventricular ejection fraction less than or equal to 35%, New York Heart Association Class 3 or ambulatory Class 4 heart failure, already on optimal medical therapy. And as we alluded to in the first talk, it's really 3 months of treatment before we consider putting a CRT in. And then QRS duration greater than or equal to 120 milliseconds and sinus rhythm. Now, that's interesting, the sinus rhythm. That doesn't mean we can't put them in AFib. It's actually a Class 2A indication in AFib, patients who have any history of AFib. So CRT really is a success story. There's strong randomized control trial data that has established the role of CRT in heart failure on top of medical therapy. And over the years, since the first CS lead was put in 1998, there's been advances in implant technology. We've already talked a little bit today about remote monitoring. This plays a really important role in CRT because we can monitor not just the device, but also heart failure. And patients can put in how they're feeling that day. Do they feel like they have more fluid? There's some monitors built into the device that look at impedances and other things we'll talk about that can help monitor heart failure and stay atop of possible heart failure exacerbations. So my topic is what's still missing. I think we have good data for using CRT. We have a very defined population we use it in, but I think there's still a lot missing. And the first thing I want to spend some time talking about is response to CRT. Because if you look back on companion, CARE-HF, really all the trials, including current trials, the response rate to CRT hovers around 70%. There's a 30% non-response rate. And when you talk about under-response, so patients who just sort of, really don't get the robust response that we'd like, it's perhaps as high as 50%. The other topic I'd like to touch on is LV lead location. And I've talked about some of the improvements in implant technology, but there's still about a 5 to 10% failed LV lead placement even today. And then lastly, I want to talk about some expanding indications for CRT for the future. So we're going to start with improving response. And this is a trial or a study that was just published that looks at how do we define response. We just talked about that with AFib. Well, this is vitally important in CRT as well. So this is a great slide. This is the 26 most cited CRT studies, and it looks at how they defined response. And there was 17 different definitions of response in these 25 or 26 studies. So it's all over the board how we define response. And what this study actually did was they took a large cohort of about 425 patients in a trial called the Prospect trial, which was followed patients prospectively before getting CRT, and it measured a variety of clinical and echocardiographic parameters prior and post to CRT. And then it applied all of these response parameters to that population of Prospect. And what they found is that 99% of Prospect patients responded to CRT by any one of these parameters, and 94 did not respond by one of these parameters. So it's the use of these parameters is fraught with problems. And when you look at correlation between an echo parameter of response, say evidence of left ventricular reverse remodeling, shrinking of the LV size, or improvement of ejection fraction, and you compare that to a clinical response, improvement in 6-minute walk time or improvement in peak VO2, the agreement is abysmal. That is here on the right. So agreement between clinical and echocardiographic response is absolutely terrible. And agreement between any two clinical or any two echocardiographic parameters for defining response, again, is absolutely terrible. So we have a real problem with how we actually define response in these patients. So setting that problem aside, how can we, before we put a CRT in a patient, predict who's going to respond and who's not going to respond? Well, one of the ways that we're looking at is really gets to the core of why we put CRT in. These are patients with usually left bundle branch block who have some electrical dyssynchrony within their left ventricle. So usually the lateral or the posterior wall is contracting late versus the other walls, and that is inefficient and causes poor ejection fraction, poor cardiac output, and symptoms. And so we can use echo, some strain-based and speckle tracking type analysis of the walls to really try to pick out those walls that are contracting inefficiently. And here on the upper right, what you see is a depiction of the strain or the squeeze of the left ventricle. And you can see that most of the walls very uniformly squeeze and sort of peak. More negative means more squeeze. They sort of peak at the same time, whereas the lateral, especially the basal and the mid-lateral wall, has this sort of upstroke. We call that pre-stretching, and then a very late peak over here, actually after the aortic valve closes. So here we have identified an area of the heart that is very inefficient. It's pre-stretching with very late contraction, and that's a potential area that would benefit from placing a lead. So this is one predictor for non-response. It's this sort of pattern on echo that we're looking at. Another predictor may be this. This is cardiac MRI of the left ventricle, kind of in a donut shaped here. And here's this inferior-posterior wall where you see the white, which is scar. That's really transmural. So you can imagine if you put a lead down here, the old adage of dead meat don't beat, you're not going to pace very well down here. So if you end up targeting your lead, and this is a very common place in the posterior wall for us to try to put a lead, this patient may not respond. But if you knew this beforehand, you might actually stick the lead more on the anterolateral, true lateral wall. And this is a study that looked at this. So if you got an MRI beforehand and you saw dense scar, didn't matter if they had dysynchrony in their heart or not, the patients just did not respond to CRT. So in the future, we may be using fancier techniques to predict non-response in these patients. And this is an example of a paper published just a couple years ago where they were looking at gene profiles of patients who got CRT. And what we know is that in heart failure, there's activation of what's called the fetal gene program, where there's abnormalities in calcium handling, there's downregulation of the fast myosin fibers in heart failure. And that CRT can reverse this gene profile. And that if you look at responders versus non-responders, there actually seems to be a difference, so that patients who were non-responders didn't have those abnormalities to begin with. And so we may be able to use in the future almost like a molecular or a genetic fingerprint of patients that are more likely to respond to CRT. So what about preventing non-response? So now we have the device in the patient. The patients come back to see you.
Kevin, before we talk about prevention of non-response, could we take a step backward and look at any clinical factors that are associated with response or non-response? And the main reason why I actually raised this question is you pointed out in companion, for example, patients with right bundle branch block versus left bundle branch block. Are there any clinical factors, for example, patients with right bundle branch block, clearly they weren't well represented in the clinical trials. Physiologically, if you think about it, it would seem counterintuitive that with the current CRT that we have today, that they would respond. So could we actually say that, patients with right bundle branch block are not likely to respond? Are there any other clinical factors that we as clinicians could use in looking at patients to try to predict their response to CRT?
I think in general we can say that patients with right bundle branch block do not respond. Now we've done a study that looked at patients with right bundles who got CRT who also had some left ventricular dysynchrony by echo, and those patients do seem to respond. But that, again, and I'll talk a little bit about this later, when it's sort of one experienced person doing these echoes who's looking at all the same patients, then I think you can use some of this technology. But as to apply it to the general CRT population, it's very difficult. So I would say in general, right bundle patients probably do not benefit from CRT. Now, whether they benefit from right ventricular pacing is another question. We're actually studying that. Right bundle is definitely one thing. The other is ischemic versus non-ischemic. And really, a lot of the results of these are driven by the non-ischemics. So non-ischemics do tend to respond better, and the more dilated a patient is, the better they respond. There is some data that suggests that's likely because it doesn't matter as much in a non-ischemic where you put the lead. Whereas in ischemic, you can imagine the infarct location is vital to where you put the lead. And we are not routinely doing MRIs, or nor were they done in those clinical trials, to target where the lead goes. So it may be that we can improve the response of ischemics simply by imaging them better beforehand, really targeting the lead. Non-ischemics doesn't seem to matter as much.
And then in talking about the severity of the LV dilation, is there a point of dilation where you would say most likely those patients are not going to respond to CRT?
That's a great question. I think all of us have that experience where you have the person come in with an 8 centimeter in diastolic diameter and the patient just doesn't respond. There does seem to be a tip over point. And I don't think that's well studied. I think all of us have that experience. There's probably other factors involved with that as well. Patients get restrictive physiology at some point when they get so dilated, and those patients don't tend to respond well. So I agree with you. I think there is a point of almost of no return as well. So once the devices are in and you get the patient back and they're just saying they're not feeling well, by whatever parameter you use to define clinical response, but for me, it's a matter of a couple of parameters. The patients tell me they don't feel well. They're on higher doses of diuretics or they're still getting hospitalized. I do an echo and I see that they have not remodeled at all. Their ejection fraction is the same. It's sort of maybe it's a group of parameters that you use. Nevertheless, you feel that the patient is a non-responder. What can we do to improve their response once the device is in? And I think one of the most important things you can do is really make sure they are using the pacemaker, so they're getting as close to 100% IV pacing as possible. And this was a study that was from last year that showed really at a cutoff of 93% pacing, patients sort of dropped down as far as their response. So if we can get more than 93% pacing, patients tend to do better. And really, if you can get as close to 100% as possible, patients do better. Now, why don't patients pace? You say we put these things in, we turn them on, why don't they pace? Well, there's a couple of reasons. Almost uniformly, the reason that I see that patients don't pace is atrial arrhythmias. They have atrial fibrillation, and the irregularity of the atrial fibrillation, they will beat out the pacemaker. Then that is almost, those patients have a very difficult time maintaining 100% IV pacing. And as already mentioned, there's a very high incidence of AFib in the heart failure patient population, 35% or greater. And so there's some thought that maybe a priori we should do AV node ablation. We should certainly be aggressive with medications to really rate control these patients. I oftentimes, if I see that the IV pacing is 85% and the patient has AFib, I will bring them back for either AFib ablation or AV node ablation to really treat that if they're a non-responder. The other arrhythmia issue is PVCs, and a lot of the devices have counters for PVC, so you can see what their daily burden of PVCs is, or you could do a Holter to get a percentage. But oftentimes PVCs will drive down the percentage of IV pacing, and higher doses of beta blockers considering antiarrhythmic, or even if it's a monofocal PVC considering catheter ablation, is not unreasonable in these patients, again, to improve their response by getting them closer to that 100%. There's programming issues. We oftentimes have fixed AV delays. We program them out of the box. We don't account for when they atrial pace, and we have to adjust the AV delays, or they exercise and the AV delay doesn't shorten appropriately. And so they will start to beat out the pacemaker. IV pacing will go down. And then less frequently now, there can be lead issues where you can't actually use the lead you put in because it's actually pacing the diaphragm or the threshold is very high. So the response to CRT is multifactorial. It's mechanical. It has to do with location of scar in the heart and where you've put the lead. It's electrical, based on the timing of the chambers and if we were able to achieve pacing or not. It's genetic, as I mentioned, the fetal genes that are activated in heart failure. And then we mentioned some of the biologic factors, ischemic versus non-ischemic. And all of these play into how patients respond to CRT. So let's move on a little bit to talk about LV lead location. And maybe this is the more geeky electrophysiology part of the talk, but I want to try to keep it relevant to patients that you'll see and why this is important. So there are definitely good and bad places to put these leads when we're in the lab. And it seems that putting it in the anterior wall is a bad place. And this is a study from 2008 that looked at patient outcomes, including death, cardiovascular death, progressive heart failure, and it stratified according to where the lead was. Was it on the anterior wall of the left ventricle? These are all left ventricular leads. Anterior wall of the left ventricle versus lateral posterior wall of the left ventricle. And clearly, if the lead was in the anterior wall, the patients did worse. So here's a venogram of a case I did maybe a year or two ago. And again, many of you may not see these all the time, but this is a catheter in the coronary sinus. Okay, here's our right atrial lead. This actually, the patient already had a device. We were upgrading them. Here's our right ventricular defib lead in the apex. And now we have just a balloon occluding catheter where we can inject contrast dye and look at these branches. And what you see is this very large branch down here, and this is the middle cardiac vein, and this goes right out to the apex of the heart. Okay, this is the anterior. This is the continuation of the great cardiac vein really into the anterior portion of the left ventricle. These are the branches we want. Okay, these little twigs right here. Okay, and it's at this point of the procedure where everybody groans, because this just turned from a 5-minute LV lead placement to a 5-hour LV lead placement, because you're never going to get a lead out these little branches. Maybe Dr. RETHINQ might get one, but I have a very hard time getting leads out these little branches. What we might do nowadays actually is try to balloon open one of these branches. It's something new that we're doing, but when I took this picture 2 years ago, I was not doing that, and so the question is, do you end up just putting a lead out here? Do you just take the anterior branch because that's all you have? So is the anterior lead better than nothing? Well, when you look at that previous trial I mentioned, the clinical response is about 30% in patients with anterior leads. And when you look at the placebo rate in Companion, Miracle, all the CRT trials, it's about somewhere between 30 and 40%. So it's as good as placebo. I guess you can look at it that way. It's no worse than placebo. So you're probably not doing the patient harm by leaving the lead there. There's a very small subset of patients who will actually improve with anterior leads, but it's difficult to know that beforehand. And so I think it's reasonable if you leave the lead there. You can always turn it off. And it's unlikely you'll make the patient worse, although you could. So but it's equivalent to placebo. The other important location that we're finding out is apical. So this was just published a few months ago by Jag Singh at Mass General, where they looked at leads being placed in the basal, mid, and apical part of the LV, and it really turns out that if you put a lead out here in the apex, and you can see this just on a standard X-ray, that the lead has, you can see here's the RV lead, and the tip of the LV lead is here, that you can divide the heart into thirds, and this lead is really out in the apex of the heart, and the patient's very unlikely to benefit with a lead that far out. So mid and apical are better. Here's the data from that, showing that survival with an apical placed lead is terrible. Now the numbers on this is a single center, and these numbers are fairly low, but still this is somewhat compelling data that we should really target the lead away from the apex, away from the anterior wall. So the patients that you see in your office or in clinic that are non-responders, what percentage have a problem with just lead location? This is from Cleveland Clinic, where they have a non-responder clinic, and they look at all of the factors, and they saw that about 20% of patients, they feel that the major problem with why the patients did not respond is because the lead is in a bad position. And again, you can see this on an X-ray. If you look at an X-ray on the patient, you can see that the lead is apical. If you look at a lateral X-ray, you can see that it's in an anterior position versus a posterior position. So you can, really sort of sort this out and decide if maybe a lead revision is what the patient needs. So here's a little bit on targeting the left ventricular lead, and maybe in the future we're going to be smarter about where we put these. And this is a picture on the left of a normal strain pattern. So here we're tracking the speckle, which is just the ultrasonographic signature of the muscle as it contracts. And on the right is a patient with dilated cardiomyopathy, where you can see the lateral, the septum just doesn't squeeze well at all. The lateral comes in early, and then the posterior wall, posterior inferior aspect is really coming in late. So if you get this kind of study beforehand, you might consider targeting the lead down to that posterior wall. And you can look at this graphically at time to how long it takes to actually contract, and you can see here that that posterior wall is contracting late. So again, this might be a place that you target the left ventricular lead. This is not well studied. This has not been prospectively studied or has not been randomized. But when you go back and you look at patients who had these type of echo studies and you look at where the leads were, patients who had leads sort of fortuitously placed on the latest wall, so the concordant LV lead position, did better as far as mortality in follow-up than patients who had leads placed at discordant positions. The other thing you can use this technology for is to find out where scar is. So you don't necessarily need to do an MRI. You can see this sort of very poor contraction on this strain analysis, and this is a same slice from the same patient where we did an echo and then looked at that scar, that dense scar in the infraposterior region. You can see also here on MRI it's not contracting well. So this one study may get you information both on scar location as well as what walls are contracting late. So where are we going with all this? Well, I think targeting the lead is important, but we're very limited with the anatomy of the coronary sinus. As I showed you that venogram, unfortunately that is not that unusual to have a venogram where you have one, possibly two targets, and you may want to put the lead on the midlateral wall, but you just don't have an option. So here's some older data from 2001, but this is starting to resurface about putting the LV leads actually on the endocardial surface of the left ventricle. And the way that you do this is you actually put a transeptal sheath across the atrial septum, and you place an LV, an active fixation LV lead into the left ventricle anywhere you want to. Here they actually put them all in the anterolateral region. The epicardial group is actually a coronary sinus lead, so our typical LV lead. And again, very small numbers here, but when you can really specifically target the lead where you want to put it on the inside of the heart, patients tend to do better. So this is actually what this may look like if you ever see this on an X-ray. If you see an X-ray like this, something either the operator is brilliant or something went really, really bad during the procedure. But this is actually the left ventricular lead going across the intraatrial septum and actively fixating into the left ventricle. Now, all these patients were on anticoagulation. There's obviously big issues with stroke risk and other things with this. So this is way, way, way outside the box. So just the summary on lead position, I would avoid anterior and apical positions. If you see that on an X-ray, then I would consider sending the patient back for maybe a lead revision if the patient's a non-responder. Consider getting some imaging before putting in one of these devices or sending a patient for one of these devices. If there's dense scar, we would like to know that, and we would potentially place the lead in a different position. Or even fancier strain analysis where we're really looking for late walls and trying to place the lead on a more targeted segment of the left ventricle. And then again, lead revision for non-responders. And I'm not going to talk much about AV optimization, but one of the first steps we often do is to really try to optimize the timing of these devices. But I will tell you, in my experience, it's very difficult if you have a non-responder to actually turn them into a responder just by optimizing the AV delays. Mostly it's issues with lead placement, mitral regurgitation, atrial arrhythmias, and those sorts of things. AV optimization or just changing the AV delays alone usually will not get you there if it's a true non-responder.
So Kevin, speaking of AV optimization, what are your thoughts about patients with persistent or permanent atrial fibrillation who are referred to you for CRT? Obviously, you won't be able to achieve AV optimization, but and when you look at the clinical trials of CRT, those patients, for the most part, were excluded from the clinical trials. Actually, sinus rhythm was one of the inclusion criteria. So what are your thoughts about patients with persistent or permanent atrial fibrillation and CRT?
I think the patients who tend to respond the best are the patients who meet a pacing indication. So if you have their tachybrady syndrome, or if you're thinking about an AV node ablation, certainly in one of those patients with a decreased EF, or even a borderline decreased EF, there's some evidence coming out that if the EF is 45 or 50 and they're having difficult times with rate control and you're going to do an AV node ablation, maybe you should put a bi-V pacemaker in that patient. Regarding optimization in AFib patients, we can do timing between the left ventricle and the right ventricle. So there is what we call V to V timing. So it's not just the top to the bottom. But it's really very incremental benefit, I think. And for the most part, you're not going to get a lot of bang for your buck doing right ventricular to left ventricular timing. I think the biggest benefit the patients with AFib get is from rate regularization and the ability to use medications if they're tachybrady.
And my final question in this regard is, does the width of the bi-V paced QRS complex predict future response to CRT in terms of improvement in any parameters or the patient's symptoms?
There's mixed data on that. There's single center studies that say yes. There's single center studies that say no. I think the best of those studies probably says yes, so that if you can get, certainly you need to get a narrower QRS duration after bi-V pacing than what you started with. And I think there's good studies that show that if you came out of the lab with a narrower QRS than what you went in with, you'll do better than if you came out with a wider. But as far as the absolute number, should you time the right ventricle to the left ventricle to really get the narrowest number, I think there's not good data for that. I do it in the lab just because I can, more or less, and I like to get a nice, pretty QRS that looks almost normal. But it has to be studied, and it is something we're studying, but there's not good data on it.
Thank you.
So the last thing, just a couple slides on what's the future. What are the expanding indications for CRT? What's in the future for this therapy? Well, there was a lot of hype and a lot of enthusiasm about implanting bi-V ICDs or bi-V pacers in patients with narrow QRSs who showed evidence of this left ventricular dyssynchrony that I've showed some pictures of, measured either by echo or MRI. There's a variety of ways of measuring this. And we, along with multiple other single centers, have shown that if you can measure and show that a patient with a borderline or narrow QRS, less than 120 milliseconds, has evidence of significant LV dyssynchrony or LV dysfunction, where walls are contracting at different times, that those patients respond to CRT, again, fraught with the error of how you define response and everything else. But these were single center studies. And the way that you actually look at this is you measure two walls. So here's the septal wall, here's the lateral wall on an echo. This is tissue Doppler. And you see a peak of the septal wall coming in early, and then you measure a peak coming in later of the lateral wall, and you measure the time difference, 150 milliseconds, and there's multiple different criteria for how you define whether this patient actually has dyssynchrony or not. You can show a picture of what the latest wall is. So again, if you were thinking about targeting the lead to the latest wall, you could use something like this. And what we know is that patients who have evidence of dyssynchrony, if they have a narrow QRS, they do worse. They have worse mortality. There's no doubt that these patients are sicker. The problem came when you tried to actually put CRT in these patients and affect outcomes. So this is the one randomized controlled trial that's been published to date that has looked at this. It's called RETHINQ and was published in 2007. And it took patients with borderline QRS durations, less than 130 milliseconds, who had evidence of dyssynchrony by echo, and it put CRT in versus just an ICD, and it really showed no difference at follow-up. Now, the follow-up was with peak VO2. That was the primary outcome. They did also look at some other outcomes. It was a fairly short follow-up. The measure they used for echo was not one of the standard measures, so there were some issues with this trial. It was also fairly small, but this was published in New England Journal. This is the landmark trial for narrow QRS, and so therefore, at this point, there's no role for CRT in patients who have narrow QRS, nor is there really a role to do echo to look for dyssynchrony in these patients. There are 1 or 2 trials coming down the pipeline that will hopefully either verify this or refute this, which may lead to a larger, sort of appropriately powered trial. This is Prospect that looked at a bunch of different echo measures, and this is the problem with all of this looking for dysynchronies, that the echo measures really are very difficult in the hands of a single center operator. They're okay, but when you really send it out to the real world, they add very little, and they're very difficult to reproduce. Here's one of the standard measures that shows variability of 33%, 72%. I mean, the variabilities are abysmal with trying to reproduce these types of measurements. And it's not that dysynchrony is not important. I think, again, the folks that have dysynchrony in narrow QRS have higher mortality, but the measures of it are not good enough yet. Last 1 or 2 slides here, looking at, again, an expanded indication. What about milder heart failure? There's a very large, nicely designed randomized controlled trial called CRT that was published last year that looked at class 1, class 2s that showed improvement in heart failure, survival free of heart failure. So it's a combined endpoint driven by heart failure hospitalization. When you put a CRT in versus just an ICD in patients with milder forms of heart failure. The big problem here is economics. This is from Companion that shows that the cost per quality adjusted life year is $43,000 for a CRT defibrillator, about $20,000 for just a CRT pacemaker. And that's, so you have to implant 12 devices to get one patient to benefit with mortality, and with the made at CRT, it's 12 devices to avoid one hospitalization for heart failure. So the question is whether that cost is worth it. And that's a big question right now. CMS has not yet rendered their opinion on whether to expand the indication of CRT to class 1, class 2s. The future of CRT, I think, is this. This is a heart failure treatment, and we can monitor heart failure through these devices by monitoring impedance. And this slide shows that by looking at impedance here measured between the left ventricular lead and the can, and what lies between those two is the lungs. So as fluid changes in the lungs, impedance will change on a daily basis. We can use that as a surrogate for left atrial pressure and monitor fluid status of patients. And then lastly, we can actually use contractility measurements at the tip of the leads to really optimize patients and really try to improve from the device the squeeze of the heart. And so patients can be optimized on a day-to-day or maybe in the future a beat-to-beat basis to really improve their function. Thank you.